Hi, it's Dr. Centeno, and thanks for joining me this morning. I know I'm at an hour earlier time than I usually do this. I had some family responsibilities later today, so we'll see how many people got the message, and hopefully we'll be able to have some folks on here to ask some questions. Today we're going to get into something that is important, but rarely ever gets talked about a lot, and that is what are the complication rates of various orthobiologic spine procedures? Now, obviously, if you're a patient, it's possible that something like this could happen. So it's pretty important that you understand what these odds are, because the good news is the risks are relatively low. The bad news is that if you're one of the 1 in 100, then that's a bad day for everybody. So I'd like to get into that a little bit today, talk about what those risks are, talk about the relative risks, because I think patients have a hard time sometimes conceptualizing what all this means for them and how it might change their behavior, or at least ensure that they go into a procedure eyes wide open. So we're going to get into that. Obviously, you've got a chance to ask questions. So if you have a question, go ahead and put it in the comments. The earlier you get it into the comments, the more likely it'll be in there to get answered. Realize that at the end of the day, I usually don't get to answer all the questions within this hour format. So if you get your questions in earlier, I'll get to them earlier. Again, today we're going to talk about spinal complications or injection-based complications and their rates of orthobiologic procedures. Now, you might be saying, well, I don't really want to know about that. I don't really care about that. Why is that important? I'm just going to hope it doesn't happen. It's important for medical decision-making because it's important to understand which procedures add more risk, which procedures have less risk, and what those risks look like. So again, if you have any questions about this or another topic, just put that in the comments wherever you are, and I'll see it here, and I'll get to that question as they come in. Just realize that at the end of the day, you want to make sure that you get questions in early, because I usually don't get to all the questions. So let's get started on this. What are the actual complication rates of orthobiologic spine procedures? And what should you think about that? And how should you use that information to try to figure out what's the best procedure for you and what you might want to avoid? So a complication rate is merely the number of serious injuries or issues that happen in X number of cases. And this is usually expressed as an incidence, or at least that's the way I like to see it. 1 in a certain number of cases. So 1 in 100, 1 in 10, 1 in 1,000, 1 in 10,000. I think patients understand that type of presentation better than me saying, 0.02%. People sometimes have a hard time saying, well, what does 0.02% mean? So I always like to quote this to patients: 1 in a certain number of cases. Now, all procedures have complications. There is no such thing as a procedure out there that doesn't have a complication rate. We know what the surgical complication rates are, and realize that complication rates sort of live in two different worlds, right? There's the one world where we see physicians or surgeons self-reporting their complication rates. And sometimes those can be pushed artificially low. Then we've got other studies that tend to look at more global information or pull experiences from lots of different clinics to try to figure out what those rates are. We know that surgical complication rates tend to be underreported in general, and these generally get reported in a range, right? With surgeries, for instance, we see, one study that shows a lower complication rate and another study that shows a much higher complication rate. So realize that these complication rates are generally expressed as a range, because some studies seem to show them lower, some studies seem to show them higher. You can increase or decrease them by increasing or decreasing the throttle, if you will, of the type of complications you're looking at. In general, when it comes to injection-based complications, if you've got more expertise and image guidance, you tend to see fewer complications. That's pretty well accepted. If you've got less expertise doing a procedure and no image guidance, you tend to see more complications. So this is a pretty practical thing to use, right? If you're going to get some sort of spinal injection and you're seeing someone who only does 10 or 20 of those injections a year, that's going to be less expertise. Or if you're seeing someone who's not using imaging guidance, they're just sticking the needle in there and going, then you're going to have a higher complication rate in that scenario than if you had more expertise and used imaging guidance. And then, as you know, there are different kinds of imaging guidance, right? We've got sort of simple ultrasound guidance, and then we've got much more complex fluoroscopy guidance, fluoroscopy with contrast confirmation, fluoroscopy with contrast confirmation, and digital subtraction angiography. So there are different levels here, and to keep yourself safe as a patient, you want to know what all of that means. So let's get into some rubber meets the road stuff here. And we'll talk about cervical facet injections. That's where a needle is placed into the facet joint, and we're injecting something in there. Now, when it comes to orthobiologics, that tends to be PRP or platelet-rich plasma being the most common. You can also inject bone marrow concentrate or other things. If you look at what the literature discusses as the risk of infection, meaning this is what's published, the risk of infection here is somewhere between 1 in 1,400 and 1 in 2,500. So that means, on average, let's split the difference there and go with 1 in 2,000. That means if you do this 2,000 times, or if you inject 2,000 facet joints, you're going to see at least one infection in there. And if we look at our personal experience at Centeno-Schultz Clinic, we perform tens of thousands of individual facet injections per year as a clinic, and we see a facet injection infection about once a decade. So they happen. I think I know of maybe 2 or 3 that I've ever seen happen at our clinic. So the good news is we're probably well below what the literature discusses the rate is, well below 1 in 2,000. But again, these can happen. And what happens if you get a facet injection that gets infected? You're going to need the antibiotics. If the facet is in the wrong spot, you don't have a lot of room in your spinal canal, that could put pressure on the spinal cord or an exiting nerve root. And realize that the good news is with orthobiologics, and we'll go through this quite extensively this morning, orthobiologics tend to be antibacterial. So PRP in and of itself is a bacterial treatment. So as you might imagine, the reason why we're probably seeing fewer facet injection infections than is what is reported in the literature is that the stuff we're using is antibacterial. Now, who's more likely to get this kind of thing? Well, if the patient is older, that's one option. If the patient is immunocompromised in some way or on a drug that blocks the immune system, those are the kinds of patients that tend to get this stuff more often, or patients that are medically sicker tend to get these things more often. Now let's go with epidural injections. Now, an epidural injection is when we inject around the spinal nerve into what's called the epidural space. Epidural literally means in Latin above or on top of the dura. So you've got the dura that covers the spinal cord and nerve roots. If you inject a small amount of stuff, epidural, you can see it flow in that epidural space, and you're doing this to try to treat a pissed off spinal nerve. Now, the literature discusses a risk of infection of approximately 1 in 1,000 to 1 in 10,000 based on the number of epidural injections you do. And the risk of a serious neurologic injury, which would be sticking the needle inadvertently into the spinal cord or into a nerve root, is about 1 in 2,000. Now, we perform thousands of these a year. I don't know within our clinic of a serious epidural infection case that has happened or serious neurologic injury case that has happened. So we're well below those numbers of 1 in 1,000 to 1 in 10,000. But again, these can happen, right? All of these complications we're talking about can occur. And again, our risks are probably lower due to the fact that platelet lysate, what we're usually injecting, or the growth factors that come from platelet-rich plasma, tends to be antibacterial. So that's probably reducing some of those infection rates. Disc injections. Now, this is where things change a little bit. And I tell patients this all the time. When you inject into the disc, we're now talking about the risk of what's called discitis, which is where we upset the bacterial balance inside the disc. And you tend to get overgrowth of something called P. acnes. Now, that has nothing to do with acne on the face. It has to do instead with the type of bacteria that is. And the risks here are much, much higher, 1 in 100 to 1 in 1,200. And so why the big range? Well, the big range here is if you look at some studies, this risk is quite low. It can go as low as 1 in 2,000 or so. If you look at other studies, the risk is quite high. So who do you believe? Always hard to tell. So that's why I quoted from basically the highest risk to the lowest risk. And so when I talk to my patients, I will say, listen, we can inject your disc, but the likelihood of a discitis is about 1 in 100 to 1 in 1,200. And then they ask, well, what does that mean if I get a discitis? It means it's a mess. You're going to need IV antibiotics. You may need surgery on that disc. Now, we perform hundreds of these per year. And I want to say that we experience a discitis case about 1 every couple of years. So we're about right in the fray here of, let's say, getting one of these discitis cases about 1 in 1,000 or so. And realize that the risk of discitis, or the risk of injecting the disc, is higher than some of these other complications we're talking about here today. This is the single most complication-laden thing we do. And it's one of the reasons why I always tell patients we want to inject outside the disc, see if that works. If that doesn't work, we'll inject inside the disc. But we want to stay away from that if we can. Let's now talk about spinal ligament injections, or prolotherapy. Now, this is a much, much harder one because there's just less reporting here in order to peg a complication rate. I suspect the complication rates of blind prolotherapy are deceptively high, but the problem is that there aren't large professional associations that are reporting these, or large registries that are reporting these. This isn't done a lot in academic centers, so we're not seeing large academic centers, reporting on tens of thousands of cases, etc. So the bottom line here is, what is this rate? My sense is with blind injections, we're talking about a complication rate of maybe 1 in a couple hundred. So kind of similar to discography, but with more imaging guidance and expertise, you can get this quite low. So I only know of one case in about 2 decades where there was any kind of serious complication, and that wasn't a serious complication, meaning at the end of the day, there was no spinal cord injury, etc. Having said that, that's a prevalence of much less than 1 in 10,000. But again, pegging what this really is in the literature is difficult at best. And my guess is that for blind prolotherapy, you're talking about complication rates of 1 in a couple hundred. Then we get into the PICL and the EPICL. That's the anterior injection through the back of the throat of the ligaments that hold the head on. Now, what is the direct complication rate here? We've done more than 3,000 of these procedures, and we've had no hospitalizations for procedure complications directly related to this PICL or EPICL, where we're coming from the front and injecting those internal ligaments. However, we could get complications as the numbers go higher, right? So let's say there could be a complication when we get to 5,000 or 10,000. And the concerns here would be deep infection, nerve injury, spinal cord injury, or other unexpected problems. So realize that if we're talking about this PICL and EPICL, the good news is we haven't seen anything serious yet, but it doesn't mean there may not be issues out there, right? We've talked about the risk of flaring up and having longer term flare-ups in some patients with the PICL and EPICL procedure, largely probably because we're talking about a very, very fragile, medically sick population that we're treating, i.e. craniocervical instability. And we've talked about other things, but at the end of the day, when it comes to more serious complications requiring hospitalizations, that hasn't occurred yet as a direct result of the PICL or EPICL procedure, but that's possible. So if we look at all of this together, what does it look like? Again, you can see up top there, I've got discography. By far the riskiest thing any clinic does is to inject anything inside the disc. And critical to understand, because I've had people come to me, hey, I want to get my disc injected. I want to get my disc injected. Great, let's talk. Let's talk about what these really are. And if you still want to get your disc injected, then we can move forward with that. It's not rocket science for me to inject a disc. I've injected thousands of discs, so not an issue, but you do need to understand the risk. Then we've got epidural injections. We put that below for sure, discography. And then we have cervical facet injections below that. Now I've got spinal ligament injections here, meaning in our hands, it's lower than the risk for a cervical facet injection. Having said that, the literature I said it's sparse here. My guess is the real complication rate for blind spinal ligament prolotherapy would put it probably higher than an epidural and lower than a disc. And then we've got the PICL and EPICL. That's the lowest on the totem pole right here, but that doesn't mean that that might not change as more data comes in. But we have enough cases, 3,000 or so, to know that the risk matrix there is not very high. So that's the good news. Bad news is it's a new procedure. It's been done less. There could be stuff coming up that we don't know about, etc. So that's how this all comes together. And again, I want to say that there's an advantage to injecting orthobiologics because they tend to be antibacterial. On the other hand, if you get steroids injected, those tend to increase infection risk, and that's well known in the peer-reviewed literature. So the good news is that if you're sticking with orthobiologics, let's say like PRP, your risk of infection probably goes down because of what's being injected. So in conclusion, complications rate can happen with any spinal injection procedure. The good news is that the complication rate with injections is about 1 in 1/10 to 1/100th that of a spinal fusion, meaning depending on the type of spinal fusion, you can see complication rates as high as 2 or 3 in 10 to as high as 2 or 3 in 100. And these are serious complication rates. So there's really none of the injections I've talked about that are in that range. So by far, if you can replace a surgery with an injection, you are probably reducing your risk of having a complication. But realize that's very dependent on whether imaging guidance is being used, and that's very dependent on the expertise of who's doing the injection. Okay, I think that's it there. I will go ahead and get this switched over here, and I will start answering some questions. Karen Johnson, hi. Hi, Karen. Let's see, Steve, you recommended curcumin when getting PRP or BMC injections to control inflammation. What about when having prolotherapy? Do you also want to control prolotherapy inflammation with curcumin? Yeah, not as much. Realize that these things act in different ways, right? So let's start with prolotherapy. Prolotherapy causes local tissue damage, usually chemically mediated, and it's like debriding a wound. So you're causing a local inflammatory response, and you're depending on that inflammatory response for the healing effect. So you're basically getting another bite at the healing apple. Now, PRP works differently. PRP works through growth factors, and those growth factors stimulate repair. There is an inflammatory component of that, so blocking inflammation isn't great, but it's less important than blocking inflammation in something like prolotherapy, because you're relying only on that acute inflammatory response in prolotherapy. Whereas for PRP, you've got other things like growth factors, exosomes that are stimulating repair. Same thing with stem cells. There is an acute inflammatory response involved, but again, the stem cells are releasing growth factors, cytokines, exosomes, etc., to help with a repair response and then differentiating into tissue. So of the three, the most sensitive to anti-inflammation is prolotherapy by far. Is curcumin probably going to move the needle with prolotherapy? Probably not, because it works through a different inflammatory pathway, the LOX pathway rather than the COX pathway. But it's probably not ideal either if you are doing prolotherapy, and it's probably going to have much less of an impact on PRP or bone marrow concentrate. Alex, after PICL1, I started holding alignment longer at about 4.5 months, even held for a month, including through PICL2. 6 weeks ago. I haven't held a week, got no x-rays to convert vectors. Curious as to the mechanism behind this. Yeah, so again, a couple of things probably going on there. The first component is there's the acute flare-up component after each one of these procedures. And, you know, it's interesting, no matter how much I beat this drum, right? There's going to be an acute flare-up period. There's going to be an acute flare-up period. It's very hard sometimes to control patients' emotions and responses to the flare-up. In fact, I'm dealing with one of these patients right now, going back and forth on email, text, etc. You know, you have to just bake it in if you're that kind of patient. Now, for some patients, this isn't an issue at all, but you have to bake in that this is going to happen with these sorts of procedures. So not at all surprising that you may need some more upper cervical chiropractic help during that flare-up. As I've always discussed, it's possible that vectors can change after these procedures. So if you're doing upper cervical chiropractic, get your vectors remeasured after the procedures, and that those vectors can change as things heal. But Alex, I would put this as just part of the normal flare-up that occurs with PICL or EPICL. Neki, do you think muscle instability scoliosis can make the same symptoms as ligament instability? Yes. So scoliosis is a side bending of the spinal column. With side bending, we always get rotation. So what does that mean? What that means is that if your neck and thoracic spine are side bent and have scoliosis, you can get a rotation component in the upper cervical spine. That rotation component can mimic, in quote, out of place, like you would see in upper cervical instability. And same thing if you get deconditioned, or if the stabilizing muscles go offline, you can also get muscular instability. So yes, one can mimic the other. So an upper cervical syndrome involving scoliosis can mimic craniocervical instability, for example. Undercover sentinel. Dear Dr. C, CCI with BAI of 5, C2 through 7 instability. Going to try PRP with adrenix as first step. Thoracic outlet 2, hydrosection of vagus, nerve, and scalenes. Too much for first-time 51-year-old female. You know, I don't know your history well enough for me to say if it's enough or too much, etc. What I can say is if you have internal ligament instability, so a translational BAI would be CCI type 1C, and that's driving most of the symptoms, then ultimately posterior type injections are probably not going to move the needle. Now, we certainly see people that go the other way, right? Let's say the translational instability or the BAI, and that's going to be skull sliding type 1C instability, may not be driving symptoms, and instead it could be C2-3 or C3-4 instability and flexion that are driving symptoms, in which case posterior injections may help quite a bit. So just realize at the end of the day, I don't know your clinical scenario, but I can say that if you've got internal ligament type instability due to skull sliding, and that's driving the symptoms, then posterior injections are going to be less successful in that instance. D07, what are the areas you would treat if you think there's trigeminal nerve involvement? Yeah, so if the person has craniocervical instability or CCI, then trigeminal nerve or fifth cranial nerve involvement involving facial pain is pretty common. So the first thing to do is to treat the CCI. You can also treat the trigeminal nerve directly, but that adds risk. And that's a good topic for today, right? We're talking about risk. Well, if we treat the trigeminal nerve directly, that's going to add risk of injury to that nerve. And that's a more complex one to do. So for example, in my office, I would trust Dr. Merkel to do that because he's done the most trigeminal nerve hydrodissections. So at the end of the day, first thing to treat in CCI patients that have trigeminal neuralgia is the CCI. The trigeminal neuralgia usually goes away. If that doesn't work, you can always directly treat the trigeminal nerve through hydrodissection. Let's see here. Undercover sentinel. Ehlers-Danlos, thoracic outlet, CCI, IJV compression, and TMJ, plus labral tear and a non-union fibula needing bone marrow. Can you do all at once, or how would you phase it? Yeah, so again, can't give you any specific medical advice because I don't know your medical history. I can say that in hypermobile patients, craniocervical instability and thoracic outlet syndrome are very common. IJV compression is probably happening due to the craniocervical instability. TMJ is also a common issue with craniocervical instability. As far as the labral tear, that's common in hypermobile patients. And then as far as the fibular non-union needing a direct intraosseous bone marrow injection, how to sequence all of that in most patients, you would probably focus on getting the non-union fibula treated as aggressively and as soon as possible. So that's going to be an X-ray guided injection of bone marrow concentrate, assuming that's the right step for that issue. I, again, don't know your clinical history. And then you may try to sequence in the next biggest thing, given what you're putting down here. In most patients, that would be the craniocervical instability, for example. So hopefully that helps. Undercover sentinel, Weber A, fibular fracture, 8 months old, consolidated in an angle, one side perfect, the other side with a 4 millimeter gap, surgical now or VMAC, to close it is okay. It's like a Pac-Man shape. Again, I don't know your clinical history. I can say that bone marrow intraosseous injections, meaning bone marrow concentrate stem cell type injections into non-union fracture gaps that are small, like you're describing, 4 millimeters, are fairly successful in helping that heal. Downside there is you're going to have to wait 3 or 4 months in order to see if that worked. But it's a pretty effective way to treat the type of non-union fractures you're describing. Casper, as a patient with suspected CCI and/or arachnoiditis, how does promoting targeted inflammation via PICL compare with seemingly opposite approach in arachnoiditis of anti-inflammatory medications? Yeah, Casper, so again, I don't know your clinical history at all. I do know that in most of the patients who I have seen who use the term arachnoiditis, they don't really have an arachnoiditis. They may have been told that by somebody, but arachnoiditis is pretty easy to diagnose on an MRI, for example. So you would get an MRI report that came back saying clear arachnoiditis. Usually what happens is the MRI comes back clean, and because things are so irritated, someone throws out the term arachnoiditis, but it's usually not. Now, I don't know your direct clinical situation. Maybe you do have an arachnoiditis. If you have an arachnoiditis, then the types of treatments for that aren't generally anti-inflammatory unless it's acute. It tends to be more things like a RAX catheter or other types of epidural injections to break up the scarring around the nerves. So again, complex question to answer in this kind of format. But at the end of the day, probably best to say that for every 10 patients I've seen in the last 20 years or 30 years that have come in and said they had arachnoiditis, maybe one of those actually did have arachnoiditis and the other ones did not. So I would really try to get that run to ground first. Undercover Sentinel of discitis at L4-5 explains step by step what would be the treatment, prognosis, and disability level for an active professional. Yeah, discitis is a mess. It's one of the reasons why, as I said before, I try hard not to inject the disc. And I've got lots of colleagues who are much more cavalier about injecting the disc and who don't really talk to patients about these risks. What I find is if I actually sit a patient down and I say, okay, you want to get your disc injected, I get it. There's maybe some real benefits to doing that. Having said that, I just need you to understand that let's say there's a 1 in a couple hundred to 1 in 1,000 chance, somewhere in there, that you might need IV antibiotics for 6 to 12 weeks. So what does that look like? That means you'll have to get a catheter inserted, and they will be giving you once a day or multiple times a day injections of antibiotics, or you'll be doing that at home. And or you'll need to get surgery to clean out the disc. And it's going to be a total mess. It'll be months and months of care devoted to trying to get rid of that disc infection. Sorry about that. Going to sneeze there. But it'll be months and months of care trying to get rid of that disc infection. So it's up to you if you really want to get that injected. Now, we're not talking about high likelihoods. We're not talking about 1 in 10. We're not talking about 1 in 5. We're talking about probably 1 in hundreds to 1 in 1,000. So what do you want to do? Solomon. Hi, Dr. Centeno, why is it that forward head posture is sometimes better to have as compensation when doing curve correction would lead to more symptoms in CCI patients? Forward head posture is never great, so I don't really understand what you're getting at there. So hard for me to comment on that one. Everybody, do me a favor and give me a like wherever you are. just because that's how other CCI patients find this content. If you like the idea that a doctor gives up a bit of every single Sunday to try to help patients by answering their questions, then go ahead and give a like right now, because that's how other people find this type of format. Undercover Sentinel, risks of multiple BMC treatments on perimenopausal osteopenic female. How many times a year can you do it? Yeah, I think what you're saying is there a risk of taking too much bone marrow and that affecting the health of that bone that you're removing the bone marrow from? Now, we did that study, and what we saw was that in non-menopausal females, that basically there was no change or reduction in the number of stem cells or other cells in that area if we sequence those about once every 3 to 6 months. Now, in perimenopausal or menopausal females, there was a drop if you did the second procedure within 9 months. Now, that's going back to the same exact source. One of the ways you can get around that is by doing 2 different types of draws. So you would start with a draw that's sort of perpendicular to the bone surface for the first one, and then for the second one, you would switch to a longitudinal axis approach going down that pelvis. So there are ways to work around it, but you're right in that at the end of the day, if you are a perimenopausal or menopausal female, you do have to be a little careful, not so much from the bone structure standpoint, because we don't see that. We don't see people developing pelvic fractures, for example, as a result of these bone marrow aspirations. The bigger issue is whether or not you're going to cannibalize the number of cells in there before they have a chance to recover. Now, again, one of the ways that you can get around all of that is usually hormone replacement therapy. And that's not going to your OB and getting estrogen. That is estrogen, progesterone, and testosterone. That is monitored closely with blood tests several times a year, usually not covered by your insurance. So in my opinion, that's a great way to end around that whole osteopenia thing, or at least delay it. But again, you've got to start that in perimenopause or right after menopause. And things have shifted there, right? It used to be that we said, don't do that. Now, as a medical community, it's shifted to we should do that. But it's not going to your OB or your gynecologist and getting started on a pill. These are injections that have to be closely monitored. It involves, again, all 3 hormones, estrogen, progesterone, and testosterone, closely monitored several times a year with blood testing, etc. Undercover Sentinel, risks of CRPS with BMAC PRP, where the best practice is, or there's some patients that simply shouldn't try it. I think what you're asking is there a risk of complex regional pain syndrome with these types of injections, or maybe is there a higher risk if someone has complex regional pain syndrome with these injections? On the latter, no, but you do have to take a less is more approach. What that means is doing fewer injections in patients that have that kind of problem so that you don't cause too much of a flare-up. Okay, Undercover, we got too many questions, so I'm going to go and try to get someone else's question here. Kara, how do you correct the reverse curve in the neck? Yeah, Kara, there's a couple different ways to go about that. Probably the most reliable thing out there that we've seen is working with a provider that is certified to do curve correction. If you go to www.idealspine.com, I don't work with them at all. I don't get anything from them, although I've referred hundreds of patients, and maybe they should buy me a gold watch one day or something. But those are the doctors that are certified in chiropractic biophysics. So again, that's idealspine.com. Those doctors can help you with getting that curve back. Casey, and to follow up question on curcumin, is it contraindicated in prolotherapy? I don't think it's contraindicated in prolotherapy. Having said that, it's not the best match with prolotherapy either. So if it were me and I was getting prolotherapy, I'd probably stop it for a week or two before the prolotherapy, and then maybe stay off of it for a couple of weeks after the prolotherapy. I think it's going to be more forgiving if you're getting something like PRP done, which is generally going to be stronger than prolotherapy, and or a stem cell type procedure. Nava, I'm about 3 months from PICL, but something happened when someone was touching my head. Now I have symptoms never felt before, like headaches, head pressure, nausea, dizziness, and burning in the back of my head. A lot of people in the group have recommended AO. I live in Denver and I've heard of Dr. DiGregorio. I've never been to an AO. Kind of feeling kind of desperate at this point. Better to consult with my doctor at CSC. Yeah, definitely better to consult with your doctor at CSC before going to an AO. We've worked with Dr. DiGregorio's clinic quite a bit. They're excellent. So, but definitely reach out to that CSC physician to determine if that's a good next step for you. JS, what does it mean to hydrodissect the vagus nerve, etc.? Yeah, hydrodissection in this context means basically under careful ultrasound guidance, it's injecting fluid around the nerve. So in this case, vagus nerve. Realize that that's not specific to the vagus nerve in that area. You're treating the superficial cervical plexus, you're treating the vagus nerve and others. And at the end of the day, in our context, it means putting platelet growth factors around that nerve, or what we would call platelet lysate, that has things in it that includes nerve growth factor, which can help the nerve. Undercover Sentinel, what is the best orthobiologics for L4-5 symptomatic fissures? I think you mean disc fissures, and then you'd have to understand if they're symptomatic or asymptomatic, meaning that just because they're showing up on MRI doesn't mean they're doing anything or causing any problems. So the only way to tell whether disc fissures are symptomatic is to do a discogram or discography, where we inject dye into the disc and pressurize the disc to see if the disc itself is causing pain. But disc fissures usually don't cause pain or problems. So just because they're on your MRI doesn't mean too much. Alex, PT recommended neuromuscular stim device. She says it activates deep muscles and then the neck. Thoughts on this? She has maybe used it while doing a posture exercise. She says it triggers muscle contractions, prevents atrophies, re-educates muscles. If you're talking about an external stimulator, like with pads that you would put on the skin, it's very unlikely that that's going to go deep enough to activate the spinal stabilizing muscles, because that's the deepest layer in the neck, underneath several layers of other muscles. So I don't really buy that using an external stimulator like that is going to do much for the internal muscles. Now, if you were to try to put in, let's say, a needle, and that needle was coated so that only the tip of the needle was left uncoated, and you would put that in the multifidus, you could stimulate the multifidus. But then you always get into the question of whether or not stimulating a muscle is enough to help the muscle rehab. So for example, not too long ago, there were all sorts of devices for your abs out there, right? You would put the external pads on and it would stimulate your abs. Ultimately, what we discovered was that stimulating a muscle with electricity isn't quite as good as actually working the muscle. So I think you'd probably do better working the muscle than electrically stimulating it. Eli, thanks for your dedication. Dr. Centeno, well, thanks, Eli, for recognizing that this is my Sunday morning. And I donate my Sunday mornings to patients in order to try to answer questions, primarily because I find that it helps to direct the conversation in a reasonable way rather than things sort of careening out of control on social media, which is common. GRT, Dr. Centeno, for a patient who had a one-sided C1, C2 facet joint injury and instability was ruled out. To what extent, maybe continues here, what extent can PRP help heal the facets of, I don't know what the second part means. So I think what you're asking here is, at the end of the day, if you have a C1, C2 facet joint injury, can PRP help that? Yes, usually PRP is a good match for that. Now, as to whether it completely heal the issue depends on the amount of damage. So if you have a small amount of damage within the joint, then in general, based on the peer-reviewed literature we have right now of what happens with PRP in joints, probably would help to heal it. Now, if you have more advanced arthritis within that C1, C2 joint, meaning more structural damage, then what do we know based on the other data that we have for PRP in joints? Based on the data we have, if it's high dose PRP, if it's injected specifically in the joint, it's probably going to be a disease modifying agent within that joint. What does that mean? It means that more likely than not, based on the data we have right now, that the PRP would stop or slow the progression of osteoarthritis within the joint. So in general, we've got lots of good data on PRP that shows that it helps joints. In our clinical experience, that extends into the facet joints because they're joints just like the joints in your hand or your knee, just smaller. D07, what measurement parameters on DMX would cause you to think ALAR involvement? What of those parameters would a person likely be sick or cause a patient likely to be symptomatic? So usually we're looking at C1, C2 overhang with open mouth lateral bending in order to determine whether or not someone has an issue with their alar or accessory ligament. So that's the movement you'd be looking at. What is the degree to which we start getting more certain that there's a problem, or at least a problem causing symptoms? And that is when there's more than 3 to 4 millimeters of overhang with an asymmetrical distance between the dens and the atlas. So those are the parameters where someone's more likely to be symptomatic. Having said that, any imaging information needs to be taken with a grain of salt. It needs to be combined with physical exam information, history, all of that stuff, so that we can really focus in on whether or not that person has symptoms coming from that instability. An image alone is not enough. Marcia, what if the alar ligaments are lightly calcified, probably due to scarring? Can stem cells, BSL, still give some improvement? I think I've answered this one before, and I'll probably answer it the same way or very similarly to how I did last time. We generally don't see calcified alar ligaments. That would be extraordinarily rare. I can count on one hand the number of times I've ever seen that. And I've looked at thousands and thousands of these. I think instead what you're probably discussing is whether or not there's a little bone spurring or traction osteophyte caused by instability and the alar ligaments. And that's completely normal and typical. So I think that's what you're describing. Bone marrow concentrate in the PICL procedure can work quite well in that situation. But again, I don't know your specific clinical information, so I can't really comment on your specific clinical issue. I can say that calcification of the alar ligament is extremely rare and something that we generally don't see. Nikki, I'm curious, do you also do the pre-screening on weekends? Yeah, on the pre-screening, I'll do it whenever they send it to me. Sometimes that's on weekends. Sometimes I'll do that during the day, during the week. Sometimes I'll do it in the evenings, early mornings, whenever I get around to do it. What Nikki is describing is that there's a pre-screening step so that we're trying to not waste patients' time. And what that means is that I will look at all of the information, mostly the imaging, and a little bit of the history to try to get a sense of, can we get to a CCI diagnosis in this patient? Or is this likely not CCI? Or do we need new information to try to get there? Because what I had found is if we don't do that, then we end up getting into a telemedicine situation with the patient. We don't have enough information, for example, to make a diagnosis. And that's super frustrating for everyone, right? The patient's super frustrated because you're like, well, I know you spent some money today. I know we've gone over everything, but at the end of the day, you need to get this image for me to be able to make a decision. That's super frustrating for the patient. So I try to avoid that by doing the pre-screenings. Nava, I've had chronic pain in my SI joint that goes into my groin due to many falls. Can stem cells, PRP help with this? I've been to physical therapy many times, it hasn't helped. Yeah, it depends a lot on what's causing the groin pain. But if the groin pain is coming from an unstable SI joint, that'd be the most common thing. Then PRP and bone marrow concentrate can be very helpful in treating that. So yes. Now, it could also just be that there's some injury within the joint, same thing, but realize that all of that tracks with what we talked about today, and that is using imaging guidance, having someone experienced in treating the entire pelvic ring. But if all of those things are met, and let's say the issue is coming from SI joint instability, which would be the most common cause of SI joint pain, then PRP and or bone marrow stem cell type procedures can be very effective in the vast majority of those patients. GRT, Dr. Centeno, I watched a video where you said in posterior injections, only 2 to 3 sides of the facet capsule can be injected by you. Is it adequate to help strengthen or heal it? Yeah, so there's a couple different layers here, GRT, I think I've talked about a bunch of times before. The first is this concept that the facet capsule provides a lot of stability. It doesn't. The second is that when providers are describing they're injecting the facet capsule, it's usually, what that usually means in doctor speak is, I don't really have the expertise to put something inside the joint, and I don't want the patient to know that. So instead, what I'm going to do is to claim that I'm injecting the facet capsule. That way they hear the word facet, they think I'm injecting the facet, but I don't know how to do that really. And so that's why I'm going to use that term. So that's the second thing. So when you hear the term facet capsule, run, because it generally means that you're talking to a provider who has no idea what they're doing. And then third, as we've talked about, the most common way to inject the facet capsule would be to inject the joint intra-articular and then inject the posterior wall of the joint on the way out. Let's say at C1, C2, you could also inject the facet capsule from the front during a PICL procedure. We've done that for patients. Injecting it on the side at C1, C2 is going to be too risky. The vertebral artery is right there. And the risk is too high of stroking out the patient. And that's one of the other things, since we're talking about complications and risks today, is you wouldn't want to do that, right? That's what comes with experience. So if you're doing a C1, C2 facet injection, going too far laterally means injecting the vertebral artery and inadvertently stroking out the patient. So you generally don't go there. Carol Yates, in advance by Sherry Scott. Have you found that CCI runs in families? I recently learned that 2 of my cousins were recently diagnosed with it after years of trying to get a diagnosis for their neck issues. Yeah, great question. I have seen that. I don't know that we know of a genetic link currently, but I have seen it and observed it in my own patient population. Kathy, are you familiar with the Gladiator therapeutic devices? I've been debating getting the cervical one as recommended by my provider. Belly issues you cannot return for any reason, and they are expensive. I haven't heard of that one. That's a new one. Let's see here if I can see what that is. Gladiator neck device. looks like a laser device, maybe. So it basically looked like, yeah, hard to say what this is, whether it's infrared, laser-based, etc. So can't say I would highly recommend a Gladiator neck device at this point. JS, are you starting at 9 a.m. going forward? Yeah, I think I am going to switch this to 9 a.m. Hopefully that works for patients, and hopefully we'll be able to get on board there. Vero, what do you recommend we patients prep for in-person consultation prior to PICL2? I don't think there's any specific prep you have to do. Obviously, there may be prep you need to do for anesthesia. There may be prep you need to do with getting off of certain meds, that kind of thing, but no specific prep. And then same, Vero, is patellofemoral syndrome treatable with PRP? It is treatable with PRP. You would want to really take a two-step approach there. The first step would be trying to reduce the friction between the patella and its groove, or the trochlear groove. And that could be through taping, usually through getting certain muscles stronger to help that tracking, or dealing with some of the issues in the hip or ankle that are causing mal-tracking. Then PRP would be a great treatment to try to help that cartilage. Okay, guys, so I think I'm coming up on the hour here, and I do have a commitment later today. So I want to thank everyone for spending some time here this morning. Let's see here. Let me just go do this last one. Who would you recommend of something to start with C1, C2, posterior injections before moving to PICL, you or a colleague, anyone in Dallas, Texas? Yeah, no one in Dallas, Texas. We're talking about C1, C2. The only recommendation is Centeno-Schultz in Colorado. It's the only clinic that we have that has enough clinical experience to recommend that high upper cervical injection. So no one in Dallas. Okay, guys, thanks so much for watching. Have a great rest of your week. I'll be here again next weekend with another interesting topic. I think we're going to keep this 9 a.m. Sunday time, 9 a.m. Mountain, 11 Eastern time for a while, and see how that goes. But thanks so much for spending the time with me this morning and for all the great questions. Again, as I always say, great questions are how everyone learns. So thank you for your time, and thank you for those questions. Have a great week.